So quickly, how do you normally breathe? So this is the normal respiratory process, all right? So movements of things in the universe go from where to where? Everything in the universe goes from high to low, right? So if you have high sodium on one side, it's going to go to the area of low sodium on the other side, right? You have high water on one side, it's going to the area where there's low water on the other side, right? That's called osmosis. Previous process of diffusion. This is the ventilation, right? Your normal respiratory cycle. And your body creates a high pressure inside the chest, right? When the diaphragm goes down, right, that's going to create a high pressure inside the chest, and therefore air is going to want to go from outside. Sorry, I said that backwards. So if you have, when you increase the volume in a chamber, right, it's called Boyle's law. That's going to reduce the pressure inside that container, right? So when a diaphragm goes down like this, the pressure outside is still the pressure outside, but you just reduce the pressure inside the chest because your diaphragm went down. So air goes from outside to inside. And then vice versa, we're going to, we exhale, we're going to make the pressure inside the chest get higher, right? Just like a piston in a car, right? We reduce the volume, that's going to increase the pressure inside the chest, and the air is going to want to go from inside the chest to outside the chest. The reason I bring this up is because this is what explains how BiPAP modes work. Our waveform is going to look like this on the monitor, and also our ventilators. So we'll see the waveforms. Oh, that's where they took a little breath, right? Because we create a negative pressure or positive pressure initially when we inhale. We create a negative pressure, right? So when I misspoke, that was a mistake. I self-correct because, oh, no, you create a negative pressure first, right? So your diaphragm goes down, makes the volume in the chest go up, right? And that increased volume is going to reduce the pressure overall in the chest, right? So if we look at this patient right here and we ventilate them, right, the air is drawn in, right? So the air is drawn into the chest because the diaphragm went down. You see the diaphragm in the bottom right corner went down. The air all got drawn in, and then we are going to ventilate again, and we exhale, right? So that's the idea. So air is drawn in because we create this negative pressure. We pulled down the diaphragm, we created a low pressure, and air is going to be drawn into the chest until it equilibrates, right? And then we're going to forcefully exhale. We're going to push the diaphragm up, right? And that's going to make the air leave, right? And then we're back to square one. So that's the idea behind inspiration and expiration. That's the normal process, right? So we look for this on the ventilator. We look for this little drop in pressure, right? And the ventilator looks for it too, and the BiPAP machine looks for it too. So they're taking a breath. Let me. They're going to do positive pressure at that point, right? So they're able to support the patient and work with the patient whenever they take a breath, right? And the RT could go in there and change that trigger. They can make it less sensitive or more sensitive. Okay, so that's the idea behind normal ventilation. Okay, so this is another explanation.
Let's talk about an open pneumothorax. So as you can see here, we have our lung in the bottle here. And so we know that when we are ventilating, inhaling and exhaling, we're manipulating the thorax pressure, the pleural space pressures, and creating negative pressure to inhale and exhale, as you can see. Inhale, exhale, inhale, exhale. But if we have an open thorax, so I just created a little hole here that manipulating our open pneumothorax, an open pneumothorax. And so look what happens when I try and deflate, when I try and inflate that balloon. I can't create any negative pressure in the pleural space. And if I can't create any negative pressure in the pleural space, then I'm not able to inflate this lung appropriately. That's going to be a big problem. So that's why we want to try and seal it and make sure that we can create negative pressure in order to inflate that lung again. That's how an open pneumothorax can be a real big problem if we're not intervening.
Okay, so that's the idea. That's the importance of maintaining that negative pressure inside the chest at all times, so you can actually draw breath in. All right, so CPAP or PEEP or BiPAP, EPAP. All right, all these things are the same, right? All these things are raising the pressure inside the chest and not letting it get anything less than that, right? So continuous positive airway pressure or CPAP, this guy is going to simply raise the pressure, right? All it's doing is say CPAP of 5. Okay, normal respiratory cycle, all we're doing is raising it by 5 points, right? So if we look at the normal waveform here, it's exactly the same as the previous slide. The only difference is that it's not starting at 0, right? It's starting at +5. All right, so it's going up by X amount, whatever you want to improve, whatever you feel will improve the patient, right? Usually we start at 5 and then we go to 8, we can go to 10 or 12, right? Usually after 10, like I said, it's probably time to intubate, right? Because 10 is a lot of support. Okay, so this is just creating a PEEP inside the chest. So CPAP is equal to PEEP. We're raising the pressure inside the chest. There's no the ventilator or the BiPAP. They both have CPAP modes. They are not, going to intervene with a breath, right? If they were to intervene with a breath, you would set a tidal volume. Say, hey, give 400, or do this, or do that, right? So all we're doing is saying go up to PEEP of 5, right, or CPAP of 5. Right? All we're doing is increasing this by whatever amount. Okay, and the way it's worded, so we're gonna have different slides for every mode. I'm gonna write it down in quotes how you say it, so you don't sound silly when you talk to the physician. Like we're on 5 of pressure. So what are you doing? So no, we're on CPAP of 5. That's usually how it's kind of worded. Okay. And again, you can look at the ventilator, you can look at the BiPAP machine, you can look at it right then and there and say, whoop, that's CPAP. How do I know it's CPAP? Because I have inhalation, exhalation. Inhalation, exhalation looks exactly like a normal waveform. And then BiPAP. So how does BiPAP work? All right. So like I said, the EPAP on BiPAP, that's where we're gonna be ending at, right? We're not gonna pressure the chest get anything less than that. And CPAP is the same as EPAP, is the same as PEEP. So that's can definitely help the oxygenation. And then we have the IPAP, right? So it's once it detects the patient breathing, it's going to change the pressures in the chest and it's going to make it go up to a certain point, right? So what we're going to see here as we ventilate real quick, you can see it's going to detect that inspiration, right? Here's our normal inspiration right there. We're right there. We are inspiring, right? So you're inhaling. So I'm gonna kick in and I'm going to all the way up to a certain level, right? That's my IPAP. Okay, so IPAP of 12 or IPAP of 16, right? So it's going to go all the way up to that amount. Okay, and then we're going to let it finish, right? Does it let it go all the way down to 0? No, right? It's going to go all the way down to whatever you set the EPAP to, right? Because that's going to help oxygenate. So that's where we finish, and that's where we start over there. So this is +5, right? So if it was IPAP of 16, let's say, that's 16 over 5, right? So it detects the little breath right here. It says, oh, you're taking a little breath. I'm going to interject at this point, and because my master, my RT, and my nurse, and my provider told me to go up to 16, and then all the way down to 5. 16 to 5, right? So it's going to adjust it's going to affect your tidal volumes based on this difference here, right? Because this is not just free air, right? This is actually, you're drawing air into the chest, right? And you have to exhale that, right? So you draw the air in, you exhale it. So this is your tidal volume that we're changing, right? So if we make that IPAP 12 over 5, that's less tidal volume, right? This is how BiPAP works. It's going to blow off CO2 by either improving tidal volumes or reducing tidal volumes. That's up to us based on the difference in the numbers. Okay, so you can see here is normal CPAP waveform, right? All it does is push the normal waveform up, right? So this CPAP of what? CPAP of 10, that's it, right? And then you can say, well, this patient's on BiPAP of something over 10, right? Didn't let it get anything less than 10 because that's our lowest number. But it went up more than 20, which is kind of danger territory, which we'll talk about in the next slide, right? Usually you don't go higher than 21 on BiPAP, right? Just like in blackjack, right? So you don't go any higher than 21 on your BiPAP because it has the risk of closing off the glottis. There's a lot of great pressure, but it just slams the door shut on the upper airways. Okay, so how do you read BiPAP to someone? Say, well, what are they on? Oh, they're on BiPAP 10 over 5 or BiPAP 16 over 6 or in this situation, or they're in BiPAP 12 over 5, right? Backup rate can be important, right? But it's not really going to have any drive to the patient. It's not going to like make them breathe at this rate, right? So you always hear people say, oh, the backup rate's this. It doesn't really matter, right? It's not going to fix the patient when you if you change the backup rate, make it higher or lower, like you would on the ventilator. Okay, and of course you want to know how much FiO2, right? So they're on 12 over 5, 60%, or they're 100%, 12 over 5. So whoa, you got opportunities, right? What can we change? What can we suggest to change if someone's on 100% FiO2, 12 over 5?
So that example is like 20 over 10.
Yeah, so you can improve that, which number? The top number or bottom number?
The top right.
Bottom number, right? So if they're 12 over 5, 100%, right? We know two things can affect someone's oxygen, right? So we can increase the low number, the EPAP, right? We could go 12 over 8, let's say, or 14 over 8. Let's increase that bottom number to help oxygen, because it sounds like you have an oxygenation problem, okay? If it's 12 over 5, 100%, yeah, they could have a CO2 problem. We just have to look at the ABG to see why do they have that big difference, right? What's going on? Right, but there shouldn't be that much disconnect, if you see what I'm saying, right? It was like 14 over 10, or it's like, let's say 16 over 10 and 100%, so that's a sick patient, right? They're on a PEEP of 10, right? They are on it, they're really oxygenated them, right? And if they're really gaining CO2, we can, instead of 16 over 10, we can go to 18 over 10 or 20 over 10 to help blow off some more CO2 also. So BiPAP, by level, it's able to do two things. It affects, you can improve the oxygen, you can also improve the CO2. All right, and BiPAP is actually like one of our most complex modes of ventilation. So one of our more complicated modes, aside from APRV, is called pressure control ventilation. Not pressure support, which is a weaning mode, but pressure control ventilation is where you set a pressure for the patient to go up to. Don't go any higher than this pressure. This is the pressure I want you to go to. And based on the difference between where they started and where you set, that is the volume you're going to give, right? So the volume here of 10 over 5, all right, if I shade that in, right? This volume right here is a lot less than this volume right here, 6 over 5, right? So this is more tidal volume compared to this, right? So if we want to improve someone's tidal volume, right, we are improving what value on the ABG if we're improving someone's tidal volume. If we want to fix the tidal volume higher. Nope, not oxygenation, but CO2, right? Someone's CO2 is getting high, we can make that tidal volume increase. Because again, the BiPAP is not going to fix your respiratory rate. Yes, you can set a respiratory rate, like a backup rate on it, but that's really for patients that are apneic at night, so they don't go anything less than 12 or 16, for instance, right? But for someone that's really high CO2s, we can throw them on BiPAP and try to blow off CO2, right? If they say, RTs, oh, no problem, I got you, fam, and I'm going to go ahead and, do 12 over 5. It's like, well, was that, or let's say they do like, 10 over 5. It's like, that's only 5 difference. Right? We should really be doing like, 16 over 8 or 16 over 6. That's a difference of 10. All right, that's really going to help blow off my CO2. As long as I'm less than 21 and my PEEP, my low number is less than 12, I'm probably in the right territory, right? I'm okay to continue with BiPAP therapy. Okay, so our sickest patients do use pressure control ventilation with like our ARDS patients, and that's, we don't want the pressure in the chest getting higher than a certain number. But BiPAP is kind of mimicking that, and it's letting us go up to a certain number and down to a low number, right? So up to an IPAP and down to an EPAP. And that difference will help blow off CO2 or not blow off CO2. Depends how wide it is, right? So if we see someone that's, wants to ventilate, right? We want to improve someone's CO2. 15 over 0, I'd probably say 15 over 5. I probably wouldn't go all the way to 0. But that's a difference of 15. That's definitely going to blow off some CO2. Compared to 15 over 10, is that going to blow off CO2? Not maybe tomorrow, right? But right now, that's going to help improve someone's oxygenation, right? So that's the idea behind BiPAP settings, right? If we want to improve someone's oxygen levels, we're going to increase the EPAP, right? So if they're like setting like 84%, it's like, well, shoot, what else can I do? They're on 100% at BiPAP. Well, what are the settings, right? If it's 12 over 5, I got room, right? Let's go up on that low number to improve their oxygenation. Okay, changing the top number and lowering the bottom number. Any one you want to do is going to widen that difference and improve someone's CO2 if they have the respiratory effort. If they're unconscious, they're not able to breathe good, that you can do all the changes you want, but it's not going to be working, right? Because you have to have a awake patient, a awake-ish patient. Okay, so again, if we want a bigger tidal volume, we're going to be changing those numbers. Right, so we're blowing this air into the chest, and you can actually measure the pressures that you're getting on the other side. And we'll talk a lot more about these pressures when we get to the ventilator. When we don't put on a patient on a ventilator, we can measure the peak pressure inside the chest, right? So that's the pressure that you're delivering with that volume, right? I'm pushing 400 cc's in, right? In this case, if I change it from 12 to 16, that's going to blow a lot more cc's into the patient, and that can cause some rise in the pressure inside the chest. Okay, and we'll be talking about PIPs and PLATs and everything today as well. Okay, does that make sense? All right, so again, typical settings, just a recap, right? So the diagnosis will kind of tell us if if they should be benefiting from this, right? If they're a COPD patient, CHF patient, if they're a asthma patient, you can do this early and in the process to try to avoid intubation. Okay, and again, changing the backup rate on the ventilator is not going to fix someone's CO2 or PO2 or anything like that, right? And if it was to do something, they're trying to fix the CO2, but really in that case, we have to widen up the EPAP and IPAP, right? So we're changing these differences here. And BiPAP, we're changing the EPAP and IPAP, right? We're widening out this number here, and that will help improve the PaCO2. Changing the level here, that's going to improve my O2, right? So that's the idea. So hypoxia is always fixed on every ventilator setting ever, including BiPAP and including CPAP. Every single mode of ventilation always has what two numbers? PEEP and FiO2. Or PEEP, as it's known in a witness protection program in Mexico, it's called El CPAP, right? And if it's over in Canada, it's like EPAP, right? So it's, I don't know how to speak Canadian. All right, so yeah, so it has different names, but it's still PEEP, right? It's still the positive pressure. We're not letting anything less than inside the lungs. So we're keeping our lungs open at all times. We don't want our lungs to go all the way down to a deflated state, right? If you ever, blew up balloons for your 3-year-old niece's party, right? And you had to blow them all the way up from scratch. Besides, you have your best friend, I don't know, he has a really, really close friend who preempts them for you and keeps them nice and open. Here, I blew this one, 10 cc's, right? It's much, much easier. And this analogy is getting away from me. Anyway, so it's much easier to blow up a balloon that's already been pre-blown up, or you like stretch it, right? But you can't like stretch a patient's neck, or that's not going to work, right? But you can, keep it, you don't want the lungs to deflate all the way. Otherwise, we have to spend all this energy here to get them back up to where they were before, or that's called recruitment, right? We have to re-recruit all those alveoli again. And sometimes those alveoli collapse and they're all super sticky, they don't have a lot of surfactant, and it's really, really hard to open them back up again. Okay, so we want what's called an optimal PEEP, right? You don't want too much, that can cause problems too. But we want an optimal PEEP. Don't let anything get less than this PEEP or this EPAP, right? Or this CPAP. Those are all the same things. Okay, so hypoxia is always fixed by FiO2 or PEEP. Those are the two modes in every single ventilator mode, BiPAP mode ever, right? So CPAP is 100%, CPAP 8, right? Or BiPAP is 16/5 PEEP, right? Or EPAP, and 100%, right? So those are telling you that those things are going to affect my oxygenation. If I want to improve someone's ventilation, right? If I want to improve someone's CO2, and hopefully if I improve their CO2, I'm improving their pH, I'm going to be changing the BiPAP, the IPAP setting, right? I'm going to be raising that IPAP, making that difference a lot wider, right? So improving ventilation is what S/T, or spontaneous time, is another name for it, because again, BiPAP was copyrighted by Philips, right? I think it's Philips. It's copyrighted, so they can't use BiPAP elsewhere. So like on our machines, they call it S/T. It's like, thanks, it's just BiPAP, right? Yeah, it's BiPAP, but I have to call it S/T since this other company, copyrighted it. Cool, right? So you have to know that, oh, that's BiPAP. That's what they're doing there, right? Again, it's like someone coining, like, oh no, you can't call that pulse ox anymore. You have to call that, blue-red or blue-red sensor diode. Or it's like, no, it's a pulse ox, right? So it was copyrighted, unfortunately. So then now we have to just kind of recognize that there is a little difference. Okay, so how much PEEP should you be on, right? So on the ventilator, you go all the way up to like 24 PEEP, right? On the BiPAP, CPAP, we're not going that high. If we're getting more than 10, 12, it's usually time to consider intubation. Okay, and on the flip side with the IPAP, right, more than 20 or 21 for blackjack, right? 21 blackjack. How do I draw blackjack here? No, that's not gonna work. All right, so Jack. All right, so here's the guy here, Jack. Okay, all right, so blackjack, he has a little hat on it as well. I'm not gonna know what this is in a year. Anyway, so 21, no greater than 21. Okay, that's going to be a reason to consider intubation. Like, well, I need to get it that high. I need to get a bigger difference. Blow off the CO2. Like they might be heading towards intubation territory. Okay, So if they're on the ventilator, again, it's just enough PEEP. That's all. That's as much PEEP as you want, right? Usually up to 24, 26 the most. Okay. So PEEP is going to be great, and we'll talk about PEEP on the next slide as well. It's going to help improve open up more alveoli, improve oxygenation, and it's only going to help re-recruit alveoli that were kind of closed shut before. And when we start raising those things, there's some numbers we're going to keep track of, which we'll talk about in our event section coming up. Our PIPs, plats, and driving pressures. We got to keep an eyeball on these to make sure they're not getting too high, because you put the pressure in the chest, it can start causing problems. Okay. Also, it can lower your blood pressure, and it can also raise your ICP, which is not great. Okay. So COPD patients, they benefit. Asthma patients benefit. ARDS patients benefit from PEEP. Probably they're not going to be on BiPAP anymore. And pulmonary edema patients. Usually we start them just like 10. Right? We're going to say, I know you have an oxygenation problem. I know this is going to help push fluid aside, right? But we're going to start you all the way to CPAP of 10 or IPAP of, let's say, 16/10. Okay. So PEEP. All right. So what is PEEP? It's the same thing as EPAP, the same thing as CPAP. And again, we want optimal PEEP. We don't want to be shutting our car door multiple times, right? Besides our alveoli closing and having to reopen again and closing and reopen again, it's just like if you had a car and you're like closing, close it, reopen. You want to close it nice and gently, right, and reopen it, or not close it all the way and let it reopen, right, all the way, like a balloon, deflate it just a little bit and then reopen it, and then over and over and over, so it's nice and easy. Okay, and this prevents trauma to the alveoli, right? Because if you were to close it all the way, that's called, another fancy term for closing alveoli is called what? Atelectasis, right? So causing trauma due to atelectasis is called atelectotrauma, right? So what kind of trauma? Atelectotrauma. So atelectotrauma is due to closing and reopening, closing and reopening, closing and reopening those alveoli. So we want the PEEP to be optimal. We don't want the PEEP to get way too low where it's causing problems. We want it to be improved, right? We want to be providing that little cushion, if you will. Okay, so PEEP keeps the airways open, keeps the alveoli recruited. Okay, and this measure, we can actually measure this difference here, and that difference is called the driving pressure, which we'll talk about more in ARDS coming up. Okay, so it improves oxygen transport and pulmonary edema. Like we said in the previous slide, so when it comes to pulmonary edema and CHF, we're going to throw them on 10 a PEEP, right? Because we know that's going to help push all this fluid from this state to this state with PEEP. So it's helping pushing that fluid aside a little bit, and it's going to help the oxygen, instead of traveling from all this area here, just from here to here, right? It's a lot less distance traveled, right? It's like traveling the One Ring to Mordor, right? So it's better if it's just like from the Shire over to the first inn right there, right? Done, right? Whereas before, if you're going to Mordor, right, it actually took 17 years in the book for him to go from one place to the other. So we want to improve that time. Yes.
So the atelectotrauma is just secondary to whatever the disease process is, and that's something that we do.
Atelectotrauma is us. That's all us. So when all these barotrauma and ventilator-induced lung injuries and all these things are due to us not monitoring the ventilator. So we can avoid that by having adequate PEEP, making sure that the PEEP is good, so we're not getting the PEEP all the way down to the point where we're causing the shut all the way, right? So we have opportunity to improve that, right? So again, someone's like 100, like getting peak pressures all up to 40, and the PEEP is 5, right? You're going all the way to 40, and you're going all the way to 5. 40 to 5, 40 to 5. You're raising the pressures in the chest all the way to 40 with tidal volumes, and then the tidal volume goes away, and what you're left with what's inside the chest, which is your PEEP, which you set of 5, let's say. So that's a difference of 35 points, right? The goal is 15 points or less. So we got to manipulate some things, and there's only 2 things that raise the pressure in the chest, and what are those 2 things? PEEP and tidal volume, right? FiO2 is just gas. It's not going to provide extra pressure. Okay, so yeah, PEEP and tidal volume are 2 things that we have to monitor, and in ARDS it becomes much more important to make sure that it is adequate, that it is not causing more problems. Okay, so again, the O2 we're going to improve pulmonary edema, improve oxygenation with in pulmonary edema by decreasing the distance it is to travel from point A to point B versus this point A to point B, right? It's much easier in this situation right here. right? It's called the diffusion distance. And if you're fancy, you can calculate it, right? There's a huge formula to figure out based on the heat and the way the molecule is shaking throughout going through the fluid, right? Oxygen does not travel well through fluid compared to through air, right? So we want there to be as much air as possible. And then when it does go through this membrane, hopefully it doesn't have like effusions in the way and fibrosis and ARDS, and then it can then nicely travel right over to the other side. Okay, so that's the idea, is to decrease that diffusion distance when we provide extra PEEP. Okay, so contraindications of PEEP. So it has all these good things, but what are some contraindications, right? It can make things worse, such as a bronchopleural fistula or pneumothorax. It's going to provide positive pressure, and that positive pressure can leak through that pleura and go into the pneumothorax space, right? And it's usually someone that has like an advanced COPD, right, or a trauma patient, for instance. So we'll reduce the PEEPs as much as possible. High ICPs, right? As we'll learn with neuro, what raises the pressure in the cranium is what the high pressures are in the chest, because your cranium has to drain fluid and blood into your chest. If it's backed up, it's going to raise the pressure in your head. Same thing with belly pressure, right? So the belly pressure is high, that's going to translate to the thoracic pressure, it's going to translate to the cranial pressure. So when you talk about ICPs, you want all three of those chambers to be optimal. Okay, and then low blood pressure. So it's great, it's going to improve oxygenation, but it's going to reduce blood pressure. It's going to reduce the return of blood to the heart, and that can also increase the workload for the right ventricle. So you might get some blood return to the heart, right? That might be fine. They might be overcoming that PEEP, but the right ventricle might have to work extra hard. Okay, it increases RV afterload of the right ventricle, makes it work super hard. Okay, so you can see here this preload is reduced, RV afterload is increased, which is not beneficial in any situation, and LV function is improved. So we actually reduce preload on the right ventricle, but sometimes that's great for someone with left heart failure. Right, someone with left heart failure does not need extra fluid to work with, so it can help them out. Right, it's beneficial in someone with CHF, but in someone who's not in CHF and just reducing the volume overall to the right atrium, that's going to reduce the volume that's being output out of the right ventricle and out of the left ventricle. And that's going to reduce the volume that I'm going to be circulating and reduce my blood pressure or cardiac output. So sometimes increasing fluid volume can help in the acute stage to fix the preload, but we have to be cognizant of when we increase PEEP, increase the positive pressures out of the chest, that can also drop my blood pressure. Okay, RV afterload is never great, right? So I'm putting all this pressure inside the chest, all this pressure is in there, all that PEEP is going up, and this right ventricle has to overcome that to pump the blood to the lungs, right? And that right ventricle is really, really weak, right? It's failing. Someone has cor pulmonale. Who gets cor pulmonale? COPDers, right? Some people lung disease. So that's going to be extra work for the right heart, and it can even get a right ventricular MI because of that. Okay, pulmonary hypertension, they're already working hard. That's going to make them work even harder. Okay, and then LV function actually gets improved. So that's a benefit of the PEEP, right? So we pushed all this fluid down into the aorta, and now when that aortic valve opens up over here, it's like, whoa, this is nice. All right, there's plenty of room for activities now. So it's able to just unload super easily. So PEEP is beneficial in that it reduces preload and also pushes some extra fluid out of the thorax into the abdominal cavity, right? But again, it's kind of double-edged sword because you can also reduce the fluid return to the heart. Okay, so that's how PEEP is beneficial.